I was asked by Eva to talk about return to sports, and I thought about if I would have been active in darts, this would have been a relatively easy workshop. But yeah, I mainly work in football, handball, and basketball, so it's a little bit challenging to do return to sports here. So it's a little bit of a hybrid version. So I'm using some videos, so not that much practical. So I'm sorry for that, but I hope you understand what the reasons are. Um, Igor Tak, who was the guy that helped me with this presentation, we work a lot together. He couldn't make it today because he has other obligations in football, but I would like to recognize his contribution to our work. Um, but before we start talking, are we really talking about the same thing, return to sports? Any thoughts? What is return to sports for you? Any guesses? Yeah? I need to use the microphone so people have. Yeah?
Being able to compete again?
Being able to compete again. If the athlete is not competitive before the injury, how do we fill in this definition then?
It doesn't apply.
It doesn't apply. So, any other definitions?
Working to pre-injury performance.
Working to pre-injury performance. If the athlete is injured in football and decides, because of the severity of the injury, to go back to football at a lower level, or maybe decides to pick up tennis, is it a return to sports?
Yes.
Is it a return to performance?
In that case, yes.
Depends on your definition. In the Bern consensus meeting, it would be returning to the same sport at the same level. So going back to tennis, it therefore would not be return to performance. Just a few examples. That's really important that we know that we need to talk about the same thing if we want to use this paradigm of return to sports. In my opinion, I think we need to change it also a little bit from our understanding. In the rehab, it looks something like this. You have an injury, and then you have rehabilitation, and then return to sports starts. And I slightly disagree with that. I think return to sports starts here right after the injury. And everything you do or do not do affects the likelihood of return to sports. And particularly the things you don't do reduce the likelihood that the athlete has a high chance of returning to sports. So it's not just one particular phase of the rehab. Of course, at one point in time you're going to be more sport specific, but the high quality rehab before is your foundation that determines your likelihood of return to sports. Yeah, so just and we know from research, and we did some survey on this matter ourselves, that the rehabilitation needs to be dramatically improved. There's a lot of potential to gain there. But now we bring the athlete back, and yes, it's good for the physio, for the strength and conditioning trainer, maybe the doctor. Athlete is back at 6 weeks or 8 months or 9 months, I don't care. That's all nice. But what about 1 year later or 2 years later? Or what about what Guus was just saying? Athlete after an ACL reconstruction comes back, but tears the biceps. Is that associated with a previous injury? And does that also contribute to the success? Or is it just, luck of the draw? What about 2 years later or 5 years later? Are the athletes still participating? What about long-term health protection? And is return to sports maybe reflecting the egos of the medical staff? Question mark. And this is not going to be my topic, because I will talk about some other things, but it's not just a biomechanical injury. There's much more going on. And we know now that there's also neurophysiological changes, that we'll be talking about that, but I don't want to underemphasize that, of course, the psychological components are hugely important. But I will focus on this one, because this is my line of work. That's easier for me to talk about, of course. For example, in this case, we looked at athletes that sustained an ACL injury, and we looked at their balance. And at 6 weeks, it was not that different from healthy controls. But what was different and how they programmed that activity. So in the brain, we saw a huge difference in brain activity compared to controls. More specifically, there was a lot of activity in the frontal lobe and there was a lot of activity in the occipital lobe. So more for the cognitive programming as well as for the visual contributions. And is that something that we consider in our rehabilitation? Because the consequence is if there are changes in the brain happening, it requires also more neurocognitive activity during sports. Is this maybe also one of the reasons why we see such high recurrent rates? Maybe, I don't know. But it's interesting to see that many athletes that do return, specifically after ankle or knee injuries, within the first year or 2 years, they sustain a recurrent injury. So why is that? So we developed this model that you could use, consider to use in your clinical setting. So when I talked about the motor part, it means like the skill you're practicing with your athlete. It could be squatting, it could be running, it could be balance, anything else. But it's important to understand that your movement, as you train it in a clinical setting, is much more different than when you train that same movement outside somewhere else. So the context in which you practice really makes a difference. Specifically, if you manipulate the sensory load, and or if you add a cognitive load on top. Because that's really what happens if you get out of the train here at Amsterdam Zuid, or if you try to cross the street. There's a lot of information that you need to pick up and process. Something to consider, I think, in rehabilitation. I want to show you a couple of examples. In ACL injury risk, there's a lot of times this very biomechanical dominated approach. So we take a motor skill and we standardize that and we apply and extrapolate that knowledge to injury prevention programs. But in reality, a skill like this that we want to use for return to sports, do you see differences compared to here? Oh, sorry. Is this a test that can assess the skill that a football player needs on the field? So am I saying that hop tests are not good? No, I'm not saying that, but I'm saying there are completely different constructs. So hop test assesses jumping and landing, but that's something completely different than playing football. So if you want to get an improvement in our understanding whether our athlete is ready to go back to sports, we need to do something that's related to football and not just jumping. It's very good for monitoring, but not, in my opinion, for return to sports decision making. That's something different. So what we have proposed to look at more an ecological dynamics approach. So you assess movements that are somewhat representative of what an athlete has to do on the field. And then see if there is a difference. And I can show you some of our work on that. I'll skip this one. We had female football players, and we had them do changes of directions. We did that in the lab, anticipated changes of directions and unanticipated. And the angles we calculated were, the cutting angles were between 45 and 60 degrees. The same athletes were also tested on the field by a 1-against-1 practice situation and in training games. And we used exactly the same changes of directions with the same velocity. So in other words, the task itself was similar biomechanically, but the context in which they were tested was different. But the biomechanical underpinnings were exactly the same. So cutting angle and the speed were all the same in all three conditions. But what we saw, for example, is that the sagittal knee plane angles in the lab are much higher than when you test them on the field. So in other words, if you do a screening test and you test your athlete in a lab, you may say, oh, knee flexion as one of the risk factors, if you want to look at it that way, is looking pretty good. It's a little bit tricky then to assume that the same movement will also be shown on the field, because that's not the case. So in other words, if you change a little bit on the parameters on movement, it has a dramatic effect on the outcome. So in other words, if you use return to sports testing in your clinic, don't assume that the athlete will show the same movement on the field. Because typically in the movement in the clinic is too standardized and too predictable. Yeah? So return to sports decision making based on clinical testing, in my opinion, is only for monitoring purposes, but not for a decision making process. So what can we do to structurally and incrementally increase the complexity? So it's not just like we're just putting exposing the athlete to more complex situation, but you want to measure that. So you move from no uncertainty to some structured uncertainty, and then eventually the athlete has to cope with chaos. Because a lot of these team ball sports is chaos, and you have to deal with that. And it's not only physical, but also psychological. Why did I say return to sports starts already right after the injury? Well, what I noticed in this girl, she did a step-up exercise. So, what does that have to do with return to sports? Well, the following. She had an ACL injury on the left, and I asked her to do a step-up exercise. And I noticed something was not right. And I wanted to assess why. So what I did is I put on surface EMG on her right gastroc. And what that revealed was that she was doing her step-up exercise mainly by pushing off with an uninvolved leg. In my opinion, this is where you can already start to identify how athletes compensate for injuries. And what they typically do is they shift load from the injured side to the non-injured side. And on the injured side, they shift load, in this case from the knee to the hip or the ankle. If you don't assess this and if you don't train this, what will happen with going up and down stairs? What will happen with squatting? What will happen with running? What will happen with jumping? So now at 9 months you do a hop test and you determine that there's asymmetry. That means that this patient probably has trained 9 months long with compensations. And I wish you all the best to try to get rid of those deficits after 9 months. It's going to be very challenging. So I think we need to identify those deficits much earlier. Also, putting in a little bit more of a challenge, I put a cup of water in there and I tell her, keep the cup in the water. And she has to struggle. And that's also important to understand if you have a patient in rehab. Don't always be too nice for them and let them practice on a skill that they're already good at. Move on to the next level. Make it difficult for them. Make it challenging for them. Yeah? Just standing for 30 seconds for 4 months as a balance exercise, it's just not going to do it. Yeah? You have to make it more challenging for them. As you can see, because she really didn't like this. Now this model comes back from the motor, the neurocognition, and the sensory. She performs a triple leg hop and watch the distance that she jumps. And we also assess the movements with sensor technology, so we have an idea about hip, ankle, and knee joint angles. Now what we're doing, we're putting these stroboscopic glasses on her. And why is that? Because we know that some patients have, as I've shown you, some sensory reorganization. They are a little bit more dependent on visual information. So what are we doing? We are perturbing the visual information. And with the stroboscopic glasses, I repeat the same test again. And you can look at jump distance, for example, but you can also look at the joint kinematics. Is there a change? You can look that she jumps a shorter distance compared to wearing without the glasses, but she also had completely different joint angles. So this might give you an indication that she is still suffering a little bit from the visual dependency. Yeah? And that could help to train her more specifically on that. So, in other words, rehabilitation is more than just strengthening, in my opinion. We need to consider that some athletes may have changes in the brain, psychological changes. That means if you've tested that, also address it. This is more for scientific purposes. We have a lab outlined where we can manipulate all kinds of stimuli, and we measure the performance with the kinematic analysis, as well as the number of mistakes that he makes, and or the the time he needs to complete the course. So it's a little bit more complex than just jumping forward, I would say. Or in this case, we add some elements. These were youth elite football players, by adding a cognitive component to a very common goal-directed task. And what we also then do is determine how athletes individually respond to those stimuli. Am I going too fast so far? Any questions so far? No? Please do so if you have any. But these are all, the standard, I think, approach on how we perceive rehab. So we determine what the rehab program should constitute of, which exercises, the specificity, the training load, etc., etc. But do you now know if that aligns with what your athlete wants? Do you know? Have you asked who works in the clinical setting with patients? Do you ever ask your patients what he or she thinks about the rehab program? Have you allowed some amount of self-control over their rehab program? Yeah. So my wife, she's doing research in injury prevention, and she's using a lot of what's called autonomy. And that means that you allow some amount of self-control of your athlete or injured athlete over the prevention program and or the rehabilitation program. Very interesting to hear how they perceive that, where they're at, whether your goals are aligned with their goals. Sometimes you find big differences. Or you may think that a patient is ready for the next level, and your athlete may say, well, I want to keep it at this level that I'm at. Important to know. Yeah? Because what we are typically involved are is this Caroline's work, is the athlete. But do you think it makes a difference if your athlete with an ankle sprain is in figure skating, or in rugby, or in American football? Could there be any cultural changes in those three different sports? And could that have an effect on the athlete and how the athlete is expected to cope with the injury? We all three were, we all four were in Lyon at the Isokinetic conference, and I was shocked to hear what athletes are, how we deal with athletes when they're injured. It was really, really, really shocking. A coach telling an athlete, I don't need you anymore, because you will never get back to the same level, so I don't need you anymore. It's like garbage or so. I mean, come on, we're dealing with people. It's unacceptable. So just to understand that what we're doing on the return to sports training and testing is only one piece of the puzzle. And whether the athlete is going back, yes or no, is also, and Guus, you have a lot of experience in that as well, it's not only medically determined, but there could also be other reasons that dictate if the athlete goes back, yes or no. To sum up, to make at least the rehab part a little bit more challenging and more fun for athletes, I would say this nicely represents it. Make it into a playground. Let your athletes explore, test it, and determine in which areas your athlete may need more development. And it's not just a matter of strength. There's much more going on that dictates how your athlete performs in complex environments. So, thank you for your attention. Are there any questions? Guus, I was asked to hand you the mic.
Yeah, very interesting talk. And then I think return to play decision making is the most challenging part of our work. What do you suggest if we can use these test batteries, for example, for ACL return to play decision making? What kind of concept or decision making steps you would advise or use? For example, a football player, last phase rehab, can he train with the team completely free or not. That's also sort of decision making.
Yeah.
What would you advise for steps to take to be able to make this decision?
That's a difficult question, and I think that's where we're lacking behind a little bit with evidence. We all have the good evidence for all the standardized and reliable tests, and I think then we slowly reach the point where it becomes much more sport specific. And do we have to have valid and reliable tests for each step that an athlete has to go through before we can say, yes, you can return? And I always return the question by, does a coach put the player on the pitch just based on GPS data or heart rate monitoring? Maybe you want to say something about it, but I guess it's also dependent on the coach's eye, what he or she perceives how the athlete is doing. And I think if we look at the model of evidence-based medicine, it's not only about research, it's about the clinical experience and it's about the expectations. And I think in the return to play, I think we're somewhere there in the middle, and we might be lacking some evidence there. So I cannot give you a scientific, sound answer on this question. I think it has to do a lot with expertise and experience.
Yeah, I didn't expect a scientific sound because we don't have the
We don't have
evidence
it.
there.
No,
Yeah.
I agree.
Yeah. I think slightly the other way around, because there is some science about those specific tests. There's
Mhm.
always a lot of emphasis on
Mhm.
those testing. We don't have the science, or it's not measurable how they function, how they perform on the field.
Yeah,
We
yeah.
all feel in practice this is much more important.
Yeah. I asked Igor last night, we know a lot about the metrics, the physical metrics of football players. And I asked him, what do we know about how many changes of directions they make? We know that also, but what are the biomechanical loads that the athlete faces, the football player faces? And is that something that we need to also use as a metric to determine if they're ready, yes or no? I don't know. Because the injured athlete has a lot of compensation strategies. So he might be going back on the field, but is he avoiding ways to reduce the load on the injured tissue? That could be, like you said about the hamstring, that could be a potential risk factor for a recurrent injury or somewhere else.
I was wondering, how much do you already use or know about real-world data that is collected on athletes returning to sports, returning to competition, and whether that goes in a positive direction or, again, in a failure, and what to learn from that?
Yeah.
From, let's say, the more bigger kind of data and real-world data that you can collect.
Yeah. Maybe you can help me out, Guus, if I'm not completing the answer sufficiently. But what I know, for example, from the football data, whether it's and Amy has done some work on that as well, is if you look at the performance metrics for an ACL injured athlete, it takes them 2 years or longer to reach the same performance level. How do you measure that? Well, minutes played, player efficiency, like it's calculated in basketball. But also, what's important, I think, to understand is what is their career length compared to the uninjured peers from the same level, the same team. So I think just putting a player back on the pitch sometimes is decided because that player, even if he's at 70 or 80%, is still more valuable than having a substitute play for him. And although he's not at the same level, he's still valuable for the team, or she, of course. So, but Guus, are you looking into metrics of your athletes returning?
Yeah, in professional football, we have a lot of data, all the data, there's a lot of stuff measured. So we're in a luxury position to have all this data. So, in return to decision making after a serious injury, all those load measures are certainly a factor that is looked at. And for example, if someone is not in his velocity of sprinting compared to pre-injury, it's something to consider. If he is not in the amount of loads in high speed running, in trainings compared to trainings before injury, that's something to consider. But it takes a lot of measurements, a lot of people, a lot of staff. So I think in professional football we have the opportunity. Yeah. And still, it's just one factor. If we are sitting together with the team, we look at this load data, okay. But then maybe much more important is if the physiotherapist who's treating this guy on a daily basis indicates, I'm feeling he's not confident. I'm feeling there's something not completely right. That's much more important than probably his load data. Yeah. I'm not sure if it's answering your question, but of course I think in the future it will be having a much increasing value in return to play decision
It's
making.
not just the quantitative, but also just ask your athlete and the other people from the team. Amy, do you have anything?
Yeah, at least in basketball, like if we actually step aside from like the pure data, the contextual factors are also a big piece that we have to look at, right? Like if at the professional level, in the NBA, players move from team to team, maybe 2 or 3 times even within one season. So it's a little different from football where players tend to stay put for longer. But NBA, you have to factor in the value of that player. Like Ali said, the same is true with the NFL. We've seen some trends where higher value players, especially if they get injured younger, are more likely to come back or come back to kind of that pre-injury level of performance. Because there's probably more investment in them, whereas those lower level players, lower draft picks, are less likely to. Again, probably those resources that are invested into those players. So how do you address that? It's a great question. Major League Soccer, there isn't a trend, but then we know we're not getting those athletes back to their pre-injury level. So is that then an investment as a whole? We don't have all those answers, but I think there's the start of looking at some of these pieces, but we still don't know all of them.
Caroline, do you want to add?
I would just go back to, we love to measure. We just want to have the number. And to be honest, sometimes I think a good example that we have, it's like the psychological readiness questionnaire that nowadays everyone say that would use in a return to sport ACL. Yeah, after 9 months, then you give a questionnaire to someone and say, how are you feeling? It doesn't make sense. It's something that needs to be like in an everyday base. Mm-hmm. And it might be, I would say, if you really want to know how I'm feeling, I would prefer that you ask than to give me a questionnaire. How confident you are about your knee. And I feel that that's what you were saying. Like if we don't have a specific number or if we don't have a specific test, ask the athlete to help you. Like I used to work with Cirque du Soleil. I have no idea how can I test someone that do a tissue act. I need to ask them, can you do something that it's close to what you were doing? Yep. And there is a triple hop test will never do that for me. So.
Yeah, that's. I'm not sure if you remember the model, but it went from controlled, no uncertainty to chaos, and on the right side it was had a checklist on competence, and the competence is exactly what Caroline says. And how do I measure competence? Yeah, just asking, and sometimes I'm looking at the movements, and then I'm aligning my analysis with the athlete and see if we are on the same par, and that's just to exchange ideas and questioning, but not is it measurable? I don't know. I don't think we should even. Last question.
Well, I think I agree that you should ask, but in top sports, different things are important for players. So sometimes they pretend that they're confident when they're not. Yeah. So then you have to have some objective standards, maybe?
I'm not sure, because there is one side of the spectrum that athletes may have fear to return, and the other side of the spectrum is that they may be overconfident for whatever reason they want to use this. Of course, we can have the standard questionnaires, but I think what you also should be aware of, certainly in sports, or if you do repeated measurements, your athletes knows what the consequences are. And I know from professional soccer also how sometimes the questionnaires are filled in a certain way, because the athlete can gain from it. So I think the evidence there can sometimes be overinflated a little bit. And I would go more with what Caroline is saying. You have to know your athlete, and you sense if it's right or if it's wrong. And it's very implicit. And I would say that's more valuable than something that's put down in quantitative measures. Or like what Guus is saying, if the physio says something is not right, then listen to that. That's my opinion. Okay. Well, I think for the sake of time, we have to stop. Thank you very much.